Amol sir.
Start it.
Amol sir, shall we start?
Yes, we should start.
Very good evening and warm greetings to respected dignitaries, judges, Maharashtra IIP President Dr. Ramakant Patil, Maharashtra IIP Secretary General Dr. Amol Pawar, State and Central IIP.
Dr. Pawar.
Hello.
Yes, sir.
Dr. Pawar, are you there?
Yes, sir.
Hi, he is there, sir.
I can't see my video. I don't know where my video is not there, I think.
Okay.
You have
पल्लवी
seen
मॅडम काय
earlier,
करता येईल
sir.
का? पल्लवी मॅडम.
Yes, sir. Checking, sir.
Sir, you are
Hi.
there just now.
Ah, yes, you are there. Just
Is
came.
there, is there.
Yes, we can see you, sir. We can see you.
Welcome. Yes, sir. You are
Okay,
there.
no, I'm just asking.
Yes, you can see, sir. We can see you, sir.
Okay, okay.
Welcome, sir.
So good
Please
evening.
start, Manjusha madam.
Yes. Good evening and warm greetings to respected dignitaries, judges, Maharashtra IIP President Dr. Ramakant Patil, Secretary General Dr. Amol Pawar, Maha IIP Women Committee Chairman Dr. Sonali Shirbate, Co-Chairman Dr. Neha Singh, State and Central IIP OBs, EBs, all the speakers, Women Committee zonal members, and all the colleagues who have enthusiastically joined to us through Zoom as well as through YouTube link for this very exciting and the most popular Tuesday Techs episode number 3 of season 2. I, Dr. Manjusha Sherkar, Maharashtra IIP Women Committee convener from Chhatrapati Sambhajinagar, and my co-moderator, Dr. Manjusha Giri, Vidarbha Zone member of WC from Nagpur, welcome you all on behalf of Maha IIP and Maha IIP Women Committee 2023. At the outset, I like to thank Dr. Ramakant Patil sir and Dr. Amol Pawar sir for giving us this platform and their consistent support to drive this webinar. Friends, theme of today's Tuesday Tech is based on pediatric neurology. MMC has granted 1 MMC point for it. Please write your name, place, CIP membership number, MMC registration number in the chat box to get MMC 1 point. Dear friends, Tuesday Techs are monthly webinar series designed by Maha IIP Women Committee in such a way that 5 speakers from all 5 zones of Maharashtra will get to share their platform for their presentations and to build a confidence. And all these talks are efficiently guided by the expert judges of the respective fields. Today, we are highly privileged to have Pitamaha of Pediatric Neurology, respected Dr. Brijesh Udani sir, and an eminent pediatric neurologist, Dr. Vinit Wankhede sir, as today's experts. Hearty welcome, Dr. Udani, and hearty welcome, Dr. Vinit. Dr. Sanjay Gosavi, Senior Consultant Pediatrician from Nasik, is today's MMC observer. Hearty welcome, Dr. Sanjay Gosavi. Welcome, Dr. Hemant Gangolia, IPP 2022. Welcome, my dear friend, Dr. Renu Boralkar, CIP EB. Welcome, Dr. Jay Bhandarkar, sir. And now I request our President, Dr. Ramakant Patil, sir, to give his blessings and give opening remarks to us. Over to Dr. Ramakant Patil, sir, our President. Hello.
Ready, sir?
Dr. Patil, sir,
Ready,
is there?
sir?
Ramakant, sir, हे झालेत, sir. Log out झालेत.
Log out झाले.
Join होते. एक मिनिट.
पुढे. Next,
Ramakant Patil, sir, you are there?
आता नाही येत, मध्ये आल्यावर बोलतील.
Okay. By that time, shall I ask Dr. Amol Pawar, sir, Secretary General Maha IIP, to say a few words?
Thank you,
Ramakant sir
Manjusha.
आलेत, sir.
हाँ. RD sir.
Hello.
Yes, sir.
Dr.
हाँ, बोला
Ramakant
sir.
Manjusha, thank you for asking me to have few words. And this already the Zoom I had been logged out. Somebody was logged in, and I couldn't log in again. So this Jadoo is of today's experts, Dr. Brijesh Udani sir. Another expert, our very own young dynamic Vinit Wankhede, and we have MMC observer Dr. Sanjay Gosavi sir from Nasik. And I really congratulate our women's committee for this wonderful Tuesday takes. And every time the very good attendance is there. And today the baton is at the hands of two Manjushas, Manjusha Sherkar and Manjusha Giri ma'am, under able guidance of Dr. Sonali Jirapure and Shirbate and Neha Singh. I really congratulate all the 5 speakers for preparing wonderful topic, and will be having experts comments on that. So this idea of Dr. Sonali Shirbate, Neha, under able guidance of Amol, we are choosing different speakers from different zones of Maharashtra, and they are usually chosen as a young dynamic people less than 40 or 35 years. And that is a wonderful idea of this. So no speaker is more than 40 years of age. And I appreciate Women's Committee and Amol for this. So we are eager to listen to Dr. Manoj Thamke, Rahul Patil, Shital Bhattad, Samruddhi Wasnik, and Trupti Bosle. And welcome, Udani sir. We are all ears again to have your expert comments. Over to you, Manjusha. Thank you.
Thank you, sir. Thank you so much for those kind and encouraging words. Now I request our beloved Dr. Amol Pawar sir to say a few words.
Thank you, ma'am. First of all, welcome Dr. Rajesh Udani sir for accepting our invitation to be there sharp at 9 o'clock for Tuesday Tech session. Then Dr. Vinit Wankhede, Dr. Ramakant Patil sir, Dr. Gangolia sir, Dr. Jay Bhandarkar sir. Welcome all the dear speakers chosen by zonal members of Women Committee of this year. Then welcome Chairperson Dr. Sonali Shirbate ma'am, Renu Boralkar ma'am, Neha, everyone. Welcome again to Dr. Sanjay Gosavi sir, who happens to be today's MMC observer. And 1 point is granted for this webinar. Without wasting much time, I straight away ask Manjusha ma'am to continue the session further.
Yes. Thank you, sir. Thank you for those words. Now for further proceedings, I request my friend Dr. Manjusha Giri to take over the proceedings. Over to Manjusha.
Thank you, Dr. Manjusha. Manjusha calling Manjusha. Good evening, all respected dignitaries. And now I call upon Dr. Sonali Shirbate, Chairman Women's Committee, to share her views about arranging today's Tuesday Takes.
Thank you, Manjusha madam. Without wasting much time, good evening to one and all. And with utmost extreme guidance of respected Dr. Ramakant Patil sir and Dr. Amol Pawar sir, we are taking this third session of Tuesday Takes with speakers from different zone of Maharashtra. And we are very fortunate to have Dr. Udani sir and Dr. Vinit Wankhede sir here on this platform for their guidance as experts. I congratulate all the speakers. Definitely they will be doing their well. And we have our both Manjushas, Dr. Manjusha Giri and Dr. Manjusha Sherkar madam for today's coordinator. And I'm thankful to Manjusha Sherkar madam and Neha Singh for this event, for this session. Because of their extreme work, we are here today with successful session today. Thank you. Over to you, Manjusha ma'am.
Thank you, Dr. Sonali. And I acknowledge presence of our today's MMC observer, Dr. Sanjay Gosavi sir, senior pediatrician from Nashik, and I request sir to say few words to our delegates.
Madam, sir nahi yet pude
Sir, thank you. Now it's time to introduce our doyens of neurology. Then our today's experts, Dr. Udani sir. Dr. Rajesh Udani sir is consultant, child neurology and epilepsy, and his affiliations are Comprehensive Epilepsy Center, section Child Neurology at PD Hinduja National Hospital, and consultant BJ Wadia Hospital for Children, Mumbai, and SRCC Children's Hospital. We all know sir is a pediatric neurologist and clinical neurophysiology. He has pursued clinical neurophysiology from New York, USA, and epilepsy from Miami, USA. Sir was president of AOCN during 2016 to 18, chairperson pediatric neurology subsection Indian Academy of Neurology from 2018 to present, and president of CNG Mumbai, organizing chairperson ICNC Mumbai 2018, and he has special interest areas of interest are complex epilepsy, medical and surgical management of complex epilepsy, then perinatal brain injury, autoimmune neurological disorders, and he has 87 papers which were peer reviewed in journals and 28 book chapters to his credentials and 7 orations, out of which Dr. Shantilal Seth oration at Petticon 2014, Nagpur, and Child Neurocon oration at Ahmedabad 2022. Now it's time to listen from our expert, Dr. Rajesh Udani, sir. Sir, please bless us with few words.
Nothing much to say. Thank you for inviting me. I think it's a good initiative which you all have taken. Gives young people the chance to present and to sort of even, read about the different parts of sections of pediatric neurology. I'm waiting to hear people, so let's not waste some more time. Let's start. Vinith.
Thank you so much, sir. Thank you, sir. Our next expert is Dr. Vinith Wankhede, sir. He is consultant pediatric neurologist and epileptologist at New Health City Children's Hospital and director of Kids Neuro Clinic, Lokmat Square, my neighbor. And he is MBBS graduate from GMCH Nagpur, DCH from BJMC Pune, and DNB Pediatric CHRC Indore. Then MNAMS and FIAP postdoctoral fellowship in pediatric neurology. He has pursued from Trivandrum Medical College, and he was editor of Indian Journal of Pediatric Neurology, National Joint Secretary, Academy of Pediatric Neurology, and National Scientific Convener of Academy of Pediatric Neurology. I invite Dr. Vinith Wankhede to say a few words.
Thank you, ma'am. Thank you. At the outset, I want to thank the women's team. And as truly said, madam is my neighbor. And it's a great initiative by MyIP, and it's good that the people all across the Maharashtra have been given the chance to say to talk on the different topics of pediatric neurology, and the topics are also widely selected. I think without wasting much time, we will proceed for the first talk. Thank you so much.
Thank you, Dr. Vinith. Now it's time to listen from our first speaker. Opening batsman is Dr. Manoj Thamke. Dr. Manoj Thamke is consultant pediatrician and neonatologist, proprietor of Wellness Clinic, Child and Skin Care from Mulund East, and pediatric. He is having 15 years of experience in private practice, and his areas of interest are pediatrics, infectious disease, asthma, allergies, neonatology, pediatric gastroenterology, and child psychology. So I invite Dr. Manoj Thamke to present his first topic on meningitis in children. Over to you, Dr. Manoj Thamke.
Please start screen sharing. Unmute yourself.
Yes. Please make it full screen.
Perfect.
Good evening, respected teachers and my dear colleague friends. Today's topic of discussion given to me is on meningitis. So I will start my presentation on the meningitis. Meningitis, as we know, there is an infection and inflammation of the fluid and membrane surrounding the brain and spinal cord. So at the outset, I will talk about meningitis, the different types of meningitis. One is infectious, what we see more commonly in the practice, and other is a non-infectious. So infectious, as we know, viral, bacterial, tuberculous, fungal, amoebic, whereas non-infectious could be malignant, drugs-induced, autoimmune condition, vasculitis. The most common condition what we see is viral meningitis, and we know there are plenty of viruses which can cause. The amongst them is enteroviruses is the most common, followed by other viruses like HSV, varicella zoster, mumps, Epstein-Barr viruses. And in enteroviruses, we get a clinical symptoms like herpangina, pleurodynia, hemorrhagic conjunctivitis, etc. The more or less the treatment of choice is IV acyclovir, and most of the time patient recovers completely. Now I will be discussing more in depth about the acute bacterial meningitis. Is one of the most common thing which we see in our day-to-day practice. It is essentially a disease of young children between 1 month to 5 years, commonly seen in poor and malnourished immunocompromised kids, and overcrowding is one of the aggravated risk factors. The pathogenesis, as we know, it is most of the time hematogenous route is common. Non-hematogenous route could be because of local contiguous site. Once the bacteria enter the subarachnoid space, it leads to the inflammation, rupture of the disruption of the blood-brain barrier, and ultimately the clinical symptoms of the meningitis. So what are the clinical features we see? As we know, with the neonate, there is nothing 100% clinical. So it could be subtle symptoms, refusal of feed, lethargy, irritability. Whereas in children, we see more common as headache, vomiting, signs of raised intracranial tension, and convulsions. Sometimes clinically, we see hypertension with bradycardia, and we see nuchal rigidity in the form of clinical signs like Brzezinski sign and Koenig sign, which are mostly we see as a positive, but it is not always. So let's come to the organism as we see in age-wise. So practically, if we see between from birth to first 3 months, it is more of the gram-negative bacilli, which are common, followed by Listeria. And after 3 months to 5 years, we see more 3 common germs like Streptococcus pneumoniae, H. influenza type B, and Neisseria meningitis. These are the most commonest things. So what are the risk factors where these conditions get more commonly leads to the meningitis? So if we consider preterm, premature rupture of membrane and NICU stay with sometimes irrational use of antibiotics, the most common thing what we is gram-negative bacilli and Listeria. Whereas other conditions like CSF leaks, we see Streptococcus pneumoniae, CSF shunts and cranial trauma, we see Staph aureus, Staph epidermidis, splenic dysfunction, nephrotic syndrome, sickle cell, we see Streptococcus pneumoniae, H. influenza, and N. meningitis. Whereas complement defects, N. meningitis, and T cell defect, again Listeria monocytogenes. So how we proceed for the investigation? So we do blood investigation where CBC, WBC count, CRP culture, and the most important is the CSF examination, which is very important. Then other investigation like multiplex biofire, AFB culture, sometimes other systemic tests like body fluid culture and neuroimaging like CT MRI. So let's proceed for the CSF picture. So what is the normal CSF study we usually see? If it is between from birth to 1 month, so usually CSF cells are more of neutrophils, that is 5 to 15, and 20 to 60% are neutrophils. Whereas protein is in the range of 60 to 90 milligram deciliter and sugar 45 to 55. From 1 month to 1 year, we usually see CSF cell between 3 to 4. Out of that 20 to 60% again neutrophil, protein in the range of 53 to 55, and sugar between 48 to 50 milligram per deciliter. Whereas once children cross more than 1 year, so usually CSF cells should be less than 6. There should be no neutrophils, and protein is normal range 20 to 40, and sugar between 40 to 18 milligram per deciliter. So any deviation from this normal parameter, we can label as a meningitis picture. So the more common feature what we see in meningitis is either viral, bacterial, or tuberculous. So here in virus, the cell could be normal to 100 cubic millimeter, whereas in bacteria, they could be even sometime more than 1000. In mycobacteria, again, they could be normal picture to up to 100, 500 cubic millimeter. The main cell types are in virus are lympho, in bacteria they are neutro, mycobacteria usually it is lymphocyte again. In protein range in virus, it is sometimes normal to 100 milligram deciliter, whereas in bacterial it could be between 50 to 500, sometimes more than 500 milligram per deciliter. And mycobacteria again has a typical different features, sometimes it could be normal to up to 100 to 500 milligram deciliter. In glucose, there should be CSF to blood glucose ratio should be less than 0.6 in virus. In bacteria, should be less than 0.4. and microbial fungal again it is less than normal or less than 0.6. So how to differentiate clinically between viral, bacterial, and TBM? So there are few clinical differentiating factors. Like in viral, it is more in older children. They have a rapid onset with fever, headache, and vomiting, sometimes focal seizures. Bacterial is a disease of younger age, fast progressive, and rapid onset, and they respond also well to the antibiotic. Whereas tuberculous meningitis could be slow onset, non-specific symptoms. Child could be malnourished. There could be significant weight loss, cranial nerve involvement, primary focus could be anywhere, and sometimes it could be normal CSF picture. Early hydrocephalus also favors in TBM. So what are the complications we see in meningitis? Is deafness, visual impairment, seizures, infarct, cerebritis, brain abscess, hydrocephalus. And what are the contraindications for CFC studies? The absolute contraindication are the raised intracranial pressure, local infection at the prick site, and if there is obstruction or impending herniation, CSF should not be done. Relative contraindications will be sepsis, hypotension, coagulation disorder, or GCS less than 8. Now, what is the indication? What are the indications for neuroimaging? If the GCS is less than 12, we should always go for neuroimaging. Status epilepticus, any focal deficit, raised intracranial pressure. So these are the indication, and MRI is more desirable over the CT scan. So if we consider the treatment part, the first thing is airway breathing circulation, as we all do. Then the second thing is antibiotic. We depend on the duration as well as type of organism grown in the CSF culture. Corticosteroids are debatable, and supportive therapy also main therapy along with the antibiotic medicine. So if we consider antibiotic profile, so for simplicity, I have made between 0 to 3 months. The more common organism are gram-negative and Listeria. So the choice of antibiotic is ampicillin plus aminoglycoside or ampicillin plus cefotaxime. And about 3 months and above, these three common organisms are Streptococcus pneumoniae, H. influenza, and meningitis. The drug of choice are vancomycin plus third generation cephalosporin, either cefotaxime or ceftriaxone. The gram-negative bacillar duration is usually between 21 to 20 days. IV therapy. Streptococcus pneumoniae vary between 10 to 14 days. Neisseria meningitis between 5 to 7 days, and H. influenza between 7 to 10 days are the duration of therapy. Now we'll touch upon one vaccine preventable neuroinfection, though we are discussing meningitis, but I will briefly cover all infection where we can prevent. So in viral meningitis, what we do: varicella vaccination, MMR vaccination, GE vaccination, influenza, sometimes rabies, pre and post exposure yellow fever. These are the vaccination available which can be considered. Bacterial meningitis, though we have three common organisms, pneumococcal, meningococcal, H. influenza, we cover most of these vaccination, though we should cover each and every child should be receiving this vaccination. And for tuberculous meningitis, though we give BCGs, but still we have tuberculous meningitis in cases. So I will suggest some take-home message from my side. Absence of fever or meningeal sign doesn't always exclude meningitis. Appropriate antibiotics should be given in all suspected meningitis, even if LP is delayed. Neuroimaging before LP is not routinely needed. CSF culture is the gold standard for organism detection, and primary vaccination against three common mosquitoes like pneumococcus, HIV, and meningitis is a must. Thank you for patient listening.
Thank you, Dr. Manoj Thamke, for covering this topic in such a short manner. And I request Dr. Udani sir for expert comments. I invite him, sir.
You can stop sharing.
Thank you, Manoj, for a very nice talk. I think it was comprehensive. I know you had to go a little fast because there was a lot to cover, but I think you covered most of it. Just a few points. I think you made a very good point about non-infectious meningitis. And the other thing is unusual infections. And this is not commonly seen, of course, bacterial, viral, etc. is important, but parasitic is one more condition. Therefore, you always look for eosinophils in the CSF. And sometimes, you require special expertise for that. Second point is you made about neonates. The reason, why neonatal have very non-specific symptoms, as you emphasized. And the problem is that very often antibiotics are given before the CSF is done. Many reasons for parental problems. They don't agree, or the patient is very sick, or just that, it's routinely kids are given antibiotics in NICUs. And that has two effects. One is we've seen patients who develop occult ventriculitis. So you suppress the infection in the meninges, they in fact may go home and then come back a few weeks later with hydrocephalus and all that, because the ventriculitis has not been completely eliminated. And of course, nosocomial infections also on the rise because of this irrational use, as you mentioned. Otherwise, I think you emphasize very importantly blood glucose, which should be done before the CSF in every case, because if you do it afterwards, your glucose may rise because of stress. Blood culture is very important, which you mentioned. Only one point I would like to say, the raised ICP, I agree with you that obviously one has to be careful in older children especially, but raised pressure is part of meningitis. You have raised pressure, but generally the pressure is raised all over. So the risk of herniation is small. And one thing you should not do is wait for imaging. If you suspect meningitis, you might go wrong a couple of times, but most of the time, if there are no focal deficits, there is not a very deeply comatose kid or something of that sort, I think CSF should be done as early as possible before antibiotics are given. I think, we don't use steroids very much in India because in abroad, as you know, to prevent deafness, they recommend steroids before the antibiotics are given. But in developing countries, the problem is antibiotics very often given before they come to before the CSF is done and before meningitis is diagnosed, and then you give the steroids, it doesn't really help. So I think that's the important point. I think most of the topics he's covered are very good. If you want to give any comments or questions, Vinith?
Yeah, thank you, sir. So I think most of the suggestion what I have went through earlier is already he has covered all those suggestions, but just the extension of the same point as what sir was saying, there's always a problem that the antibiotic is already given at the primary center and the patient is at the secondary or tertiary center where most of the pediatricians are working. So we often get our blood cultures or CSF cultures negative, and that's the reason we are how long the antibiotic should be given if your cultures are negative. So in such cases, if you have at the secondary or tertiary setup, I think the PCR based tests are quite useful, because even if you have the bacteria or virus is dead, it will pick up the by PCR. So it will guide us for the overall, because to avoid this, especially neonates, where if you don't treat it adequately, it may lead to ventriculitis or complicated meningitis. I think that's the only point I want to. Thank you.
Thank you, Udani sir, and thank you, Dr. Vinith. And I request all the delegates to write questions in chat box, which we are taking after all these sessions. So we will move to our next topic. I request Dr. Rahul Patil, to share his screen meanwhile. Dr. Rahul Patil, our next speaker, he is from Dr. Rahul Patil, our next speaker, he is from Dr. Rahul Patil is MBBS, DMB, FPCC, and ID. Rahul Patil is MBBS, DMB, FPCC, and ID. He is ex-assistant professor PICU, BJ Wadia Hospital. Assistant professor PICU.
राहुल सर तुमचा माईक सुद्धा बंद करा. राहुल सर तुमचा माईक सुद्धा बंद करा.
Okay,
YouTube बंद करा सर. YouTube बंद करा. YouTube. So Dr. Rahul Patil is ex-assistant professor PICU, BJ Wadia Hospital. He is ex-consultant intensivist at Sai Child Care Hospital, New Panvel, and consultant intensivist Niramai Child Care Hospital from Jalgaon. And he is director of Tarangan Child Care Hospital, Jalgaon, and he was part of TOT in GEM course at Indore and TRAC module at Mumbai. So over to you, Dr. Rahul Patil. Please share your screen. Share your screen.
Good evening, everybody. Thank you, IAP, for providing me this opportunity. Without wasting time, I'd like to continue with my presentation. So, seizure disorder, it's a very big topic to cover within just 8 minutes, but I'll try my best without wasting time. So, the incidence is around 0.5 to 1% in.
Screen.
Yes, ma'am. So it is an incidence around 0.5 to 1%. Seizure, it's like a single episode where there is a transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. And if it happens again and again, so it becomes epilepsy. So chronic disorder with recurrent unprovoked seizures. Recently, International League Against Epilepsy has classified depending upon the type of onset and the awareness. So basically, we have, if the onset is focal, becomes focal onset. If its onset is generalized, becomes generalized onset, and if it is not known exactly, it becomes unknown onset. Sub-classified, depending upon the awareness. In focal onset, it becomes focal aware, which was initially like a simple partial seizure, and with limited awareness, it becomes a complex partial seizure. Again, sub-classified depending upon the motor and non-motor symptoms like tonic, clonic, or hyperkinetic. And in generalized onset, it is also the same depending upon the motor symptoms, either tonic, clonic, myoclonic, accordingly, and non-motor or absent seizure, we say, maybe typical, atypical. And in unknown onset, depending upon the behavior, non-motor, and in unclassified, there are certain epilepsy syndromes. So before labeling it as a seizure, we should know what is not seizure. In neonates, hypoglycemic attacks, 6 to 18 months of age, breath holding spells, 11 to 18 years of age, transient ischemic attacks, teenagers, panic attacks, physiological jerks during sleep, psychogenic episodes in adolescents, and syncope. Etiology may be vascular, like stroke, hemorrhage, infection. Last talk we have seen trauma in accident or accidental fall, autoimmune in certain autoimmune disorders, metabolic like hypoglycemia, hyponatremia, or electrolyte imbalance, idiopathic, neoplasm, and certain drugs which can cause these seizures. Now, how to diagnose? So, for the diagnosis is very important for better treatment and improve the quality of the life. So clinically, if you go, the detailed history of the event is very important, whether it's a localized or generalized jerks, there is any eye deviation over the sensorium, was there any history of injury or associated incontinence, then post-ictal drowsiness, confusion, headache, or there is any aura before the episodes. Then video recording, in case certain parents, in the known case, they have some video recording, and in known case, how is the compliance, whether there is any missing history of any drug. Then in examination, detailed physical and neurological examination, associated neurocutaneous markers, subject nodules. Then fundus examination, evidence of papilla edema, hemorrhage, focal neurological signs, and detailed developmental history. The child with developmental delay may get seizure at some point of time in his life. EEG, neuroimaging. Now let's talk about EEG. Ideally, it should be done in all seizure cases. Avoiding antiepileptic drug before EEG is not advisable. So any child coming with seizure, for the purpose of EEG, we should not avoid EEG. Repeat EEG before stopping the treatment to guide withdrawal of the treatment. Benign Rolandic epilepsy, where the classical centrotemporal spikes are there in the EEG, the diagnostic. We don't need any neuroimaging after that. Now, neuroimaging, when should be done? Ideally, MRI is better than CT, but in case of emergency like hemorrhage or fall, we should go ahead with the CT. Ideally, in all kids with focal seizure, those associated with neurological deficit, then those who have shown focal changes on the EEG, and in all neonates, all cases we need to go for neuroimaging. Now, coming to the treatment, first confirm it's a seizure depending on the onset, what we have seen in the classification. Control with the most appropriate AED as per the age. Then the first unprovoked seizure, we not need to treat it always, unless it has got some localizing signs. there are 40% chances of recurrence after the first seizure, and then thereafter increases. Parents need to counsel in detail about the risk of recurrence and the compliance to the drugs. Now, circumstances in which single seizure which we treated is if the child coming first time with status epilepticus. For clinical purpose, any child coming to your emergency OPD, ICU or OPD with seizure should be taken as a status. Then prolonged focal seizure, those kids associated with neurological deficit, hemiparesis, mentally retarded or cerebral palsy kids, those who have got a positive family history, those who have abnormal EEG even after the first episode, and history suggestive of seizure at past which may not have been recognized by the parents. Now, principles of treatment are basically already we have seen. First, unprovoked seizure, evaluate and then treat accordingly. Second, you treat and then evaluate simultaneously. Start with monotherapy, the appropriate drug without side effects. Start low, go slow. If not controlled, add second anti-epileptic dose, optimize the dose and taper the first dose. If 2 attempts with monotherapy fails, in that case we need to use combination therapy, but here we need a specialist opinion. Then certain modified release formulations are also available. We should take into consideration that. Now, how to choose? The slide looks very complicated, but simply once we classify it as per the onset and awareness or in epilepsy syndrome, if it's focal, the drugs are carbamazepine, oxcarbazepine, phenytoin, valparin, and phenobarbital. In case of generalized seizure or epilepsy syndrome, and in undetermined cases, valparin, phenytoin, or phenobarbital will be the choice. Valparin is the drug of choice for myoclonic jerk, absence, and generalized epilepsy syndromes by and large. Now, something about status epilepticus. Any child coming with convulsion to the OPD, I lastly said we should take it as a status. Continuous seizure lasting for more than 5 minutes or 2 or more discrete seizures between which there is incomplete recovery of the consciousness considered as a status. If even with 2 anti-epileptic drugs not settling, it should be considered as a refractory. And if it continues or recurs despite of 24 hours of generalized state, it becomes super refractory. This protocol we all know is an emergency protocol managed ABC with line secured, blood samples including electrolyte, calcium, sugar, quick examination in case of low glucose group, sugar bolus. In the case of neonate, pyridoxine we can consider. Then first choice is benzodiazepines. Then second choice either phenytoin, Levera, or valparin we can choose. Optimize the dose. If not control, use second dose. Once it becomes refractory, in that case, we'll have to take in consideration RSI intubation and further higher next level of anti-epileptic drugs. Now, certain newer anti-epileptic drugs, I just mentioned the names like clobazam, we all know, lacosamide, brivaracetam, zonisamide, and then for super refractory, we use inhalational anesthesia with halothane, desflurane, and isoflurane. As a physician, we should know certain drug interactions while using with AED. Most of the anti-epileptic drugs are enzyme inducers like phenytoin, phenobarbital, carbamazepine, and oxetol. They interact with other AED and other oral anticoagulants, especially in those cases of stroke, like where we need to use anticoagulants and AED also. Valparin is an enzyme inhibitor, hepatic enzyme inhibitor. While using certain like fluoroquinolones, anti-tubercular, and antiretroviral. In that case, we need to be careful while using with anti-epileptic drugs. Now, in certain cases like strokes, we should avoid phenobarbital and phenytoin. They have certain side effects like neuroneurological urethria and osteoporosis, and lamotrigine and gabapentin are basically recommended. In neurocystic sarcosis, depending upon the lesions on CT scan, if it's a single lesion, treat for 6 months, repeat CT, if disappear, taper in 8 to 12 weeks. But in case of multiple lesion, we better leave it to the specialist. In case of hepatic diseases, gabapentin, levetiracetam, carbamazepine, oxetol are recommended without any dose adjustment. Valparin, phenobarbital, and benzodiazepines basically can cause hepatotoxicity. We need to be careful. In kidney disease, gabapentin, topiramate, and levetiracetam, they need post-dialysis dose supplementation in case if we are using those. Now, something in detail about febrile seizure, which is the most common variety of seizure, happens to be between 6 months to 5 years, always with fever in absence of cranial infection. Most of the time becomes recurrent. 50% of the cases it recurs. It can be simple or complex. Complex means what? The duration is more than 15 minutes and it happens to be multiple episodes on the single event. Lumbar puncture normally not indicated unless it happens to be in less than 1 year of life or if we suspect some CNS infection. EEG normally in simple febrile not recommended. In complex febrile seizure or febrile status we should do. EEG and neuroimaging access no role in simple febrile seizure. Now at home prophylaxis we should teach our relatives like lower the body temperature by sponging. They can use rectal diazepam or nasal midazolam which is easily available now. Oral clobazam like Frisium we use for 2 days to prevent recurrence, and recurrent febrile seizure beyond 6 years like we say febrile plus. In that case we require AED prophylaxis as per the specialty suggestion. In special cases like CPMR and learning disability, the incidence of seizure is higher around 25 to 30% and they are usually difficult to treat. Record keeping is very important. Avoid phenobarbital because of hyperactivity. No need to control all seizures. At times you may get few seizure for few minutes or seconds. In that case, we should avoid that. And antiepileptic drugs are required for long period of time. Now, non-pharmacological interventions, basically for refractory epilepsy, yoga and meditation. Yes, definitely there is a role. It increases stress hormones, reduces serotonin, and modulation of autonomic balance. So RCTs has shown some promising results. Ayurveda, it should not be recommended. Limited RCT without evidence for their use. Ketogenic diet, it's very unpalatable. We need supervision. It's a high-fat, low-carb diet, but only after specialty opinion. Herbs can cause drug interaction with antiepileptic drugs. So limited study to prove the usefulness. Then hypothermia, we say in case of neonate with HIE and convulsion, the miraculous device for that we can start cooling and hypothermia. Then neurotherapy, surgery in epilepsy. That's a limited availability in India, but for medically intractable epilepsy or resistance epilepsy, in that case we may need to go ahead with the seizure like not controlled by 2 or more antiepileptic drugs even after 2 years of treatment, or sooner in case of epileptic encephalopathy, infantile spasm, seizure frequency more than or equal to once a month, disabling seizures, and refer to specialist. Seizures not controlled with 2 antiepileptic drugs, poor control even after 2 years of starting AED, and diagnosis is not certain. And those kids on antiepileptic with abnormal behavior, intellectual deterioration, associated psychological or psychiatric comorbidity. Now take-home message first. Before this, we need to confirm the seizure as per the new guidelines classification. Establish the type, initiate the appropriate antiepileptic drug. The first unprovoked seizure, evaluate. Second one, you evaluate plus treat. Monotherapy start low and go slow. Add second drug if required with repetal of the initial drug. Earlier referral if you suspect something unusual. To follow status epilepticus protocol, and parent education equally important. Thank you.
Thank you, Dr. Rahul, for such a elaborative talk.
Thank you, Dr. Rahul, for such a elaborative talk.
Please switch off your YouTube, please.
Please switch off your YouTube, please.
Now I request Dr. Udani sir for his expert comments.
Now I request Dr. Udani sir for his.
Actually, maybe Vineet, you can go this time.
Dr. Vineet.
Hello. Yeah. So I think it was a good presentation, but I think it needs little changes. I went through it earlier, but so I think rather than saying the theoretical definition of epilepsy, we should say about the practical definition of epilepsy, which was updated in 2017 ILE, which says about the 2 unprovoked seizures. If you have any of this, if you're 2 unprovoked seizures 24 hours apart, or if you have single unprovoked seizures with the relative risk of having a second seizures exceeding 60%, or if you have a single unprovoked seizures with abnormal EEG, which is diagnostic of some epilepsy syndrome, if you have any one of these 3, you can label it as an epilepsy. And accordingly, we can treat even the single first episode also. So I think in the treatment part, what he has said that we can wait for the second episode, it's no more true. I think we should, if any one of this is there, and accordingly, if you have a diagnosing some epilepsy syndrome, the specific medicines which are for that epilepsy syndrome has to be initiated, and accordingly we can prognosticate. About I think epilepsy surgery also, so it's very promising. I think Dr. Udani sir is regularly doing all the surgeries, and we have enough centers across the country. So it's a very promising result in a subset of drug refractory. Almost 1/3 of the drug refractory cases the epilepsy surgery is a good option. Also about the ketogenic diet. So I think it's very difficult for anyone to talk about the seizure disorder in 8 to 10 minutes. But I think he did a good job. But I think a few changes has to be made, I think.
Yeah. Thank you. I think it was a great talk, covering the whole of epilepsy, right from definitions to surgery to status epilepticus, really a feat. But I agree. The first point, of course, I think what he made about the definitions have changed. You may or may not treat the first seizure, even if it is epilepsy syndrome. For example, benign epilepsies or what is now called self-limiting epilepsies, you may not treat if you feel that it's that. But that, it depends on you and the patient's parents, and you have to decide on the basis of that. The second important thing is, I think what most of us have, he emphasized hypoglycemic attacks. Actually, hypoglycemic seizures can occur in newborns, and I think the point I'm trying to make is a perinatal brain injury, and this is the bane of all the pediatric neurologists in this country. You're meeting, your drug-resistant epilepsy is almost half or maybe a little more than that because of perinatal brain injury, and I think this happens primarily because of the unfortunately, the gynecologist managing the patients in the newborn period. Everybody should have pediatricians because feeding has to be initiated, early discharge in small for dead babies. All these things can cause problems. And, the price the parents and the family pays is enormous. So I think that has to be, at a pediatrician level, you have to educate your gynecologist as well to make sure all this is done. Another point I was interested in making was, we talk about midazolam spray and nasal midazolam spray, but, you should spend a little time in how to give it. Because in my experience, when patients, the patient is having a seizure, is laying down, they don't put him on his side, and they don't raise the head. They don't raise the head. If you don't raise the head, and your spray is not, is positioned downwards, nothing will go in. And the doses have to be correctly given. So that's, those things have to be sort of properly understood. So for example, a 20 kilo, if you give a 0.5, you have to give 8 puffs. And if you have a 25 kilo, you have to give 10 puffs. But if you use 1.25, you have to give 4 puffs. So I think these things should be, and giving, these inappropriate 2 puffs and all that is not a good idea. So I think that's important for first aid, and that is the first management of status epilepticus in the making. So if you have patients who go beyond 5 minutes, you have this kind of evolving status or impending status, and that has to be prevented at home because we know that these drugs act better in the first 5 minutes. Then the same midazolam will not be as effective maybe after 20 minutes or 30 minutes. So I think that's important. I think you mentioned about surgery. I think the biggest problem we face in surgery is we don't get adequate referrals because we need to get these drug-resistant epilepsies as soon as possible. If they are surgically remediable, you must send them as soon as possible. So I would suggest, if this is, say, unfortunately a drug-resistant epilepsy, and that also is a big point because people add drugs before allowing the first drug to act fully. You're scared that, if it doesn't get controlled, let's give a second drug, then third drug, then fourth drug. And many of the times what happens is it's just a matter of dosing and, you're not given the full chance for the drug to act. Of course, the patients are impatient and they want urgently and all that, but I think that's important. And the last thing I want to say is maintain a seizure diary. Nobody maintains, especially in patients who are having frequent seizures. And how do you know that these drugs, which are basically symptomatic treatments, not disease modifying, how do you know something is working? So you have to wait for at least a baseline. He's getting 2 seizures a month or whatever it is. Now he's not got 2 seizures for 3 months. Maybe he gets 1 seizure a month. So you have 50% reduction. It's working. That's how you choose. Seizure diary is very important and it's hardly ever kept really. I think that's about it. I think it's very good, and I think it's impossible to cover the whole of epilepsy in this short time, but still, I think good job. Thank you very much.
Thank you, sir. Thank you, Dr. Rahul, and thank you, Dr. Vinit. Our next speaker is Dr. Sheetal Bhattad. May I request Dr. Sheetal to share her presentation? Thank you, Dr. Sheetal. She is consultant pediatrician from Bhattad Hospital, Latur, and her topic is cues and interventions in cerebral palsy. Over to you, Dr. Sheetal.
It is not moving, ma'am. 1 second.
Yeah, it's
Cerebral
moving.
palsy is a group of permanent disorders of movement and posture causing activity limitation that are attributed to non-progressive disturbances that occurred in developing brain. Cerebral palsy is associated with disturbances. Cerebral palsy is associated with disturbances in sensation, perception, cognition, communication, behavior, and also associated with epilepsy and secondary musculoskeletal problems. The prevalence of CP being 1.5 to 5 per 1,000 live births, varying from high socioeconomic status to lower socioeconomic status. Diagnosis of CP, early diagnosis of CP is important. So for diagnosing CP, clinical features in the form of abnormal tone, abnormal posture, presence of primitive reflexes, delayed developmental history, altered motor and sensory examination is important. According to IAP new guidelines, MRI is done only when other diagnosis of CP, diagnosis other than CP is suspected. Genetic testing is done when MRI suggestive of any cerebral malformation. We can detect CP as early as 5 months with the help of following tools like GMA, General Movement Assessment, MRI, HINE, Bristol's Qualitative Assessment for General Movements. These are some tools. Classification of CP, SCP classification, which gives us spastic CP, dyskinetic CP, and ataxic CP. In dyskinetic CP, if the tone is more and activities are less, it is dystonic CP. If tone is less and activities are more, it is chorioathetoid CP. Topographical classification is unilateral cerebral palsy and bilateral cerebral palsy. In unilateral cerebral palsy, monoplasia, hemiplasia. In bilateral cerebral palsy, diplegia, triplegia, and quadriplegia are seen. Functional classification systems of cerebral palsy, GMFCS classification, as we can see in this picture. In GMFCS level 1, the patient is ambulatory, and in GMFCS level 5, the patient is bedridden. Another classifications for functional classifications for cerebral palsy are MAX, which evaluates functions of upper limb, CFFCS, which evaluates everyday communication, EDAX, which evaluates ability to eat and drink in children more than 3 years of age. Prevention of CP. For prevention of CP, prevention of low birth weight, prevention of prematurity, prevention of preeclampsia is important. Antenatal giving in high-risk patient, antenatal Maxulf and antenatal steroids are to be given. Delayed cord clamping and therapeutic hypothermia are some preventive aspects which can be dealt for CP. Physiotherapy is very important. Physiotherapy helps in reducing spasticity and improving range of movements. Some physiotherapeutic methods and principles are given in these tables, like Bobath therapy, which inhibits primitive reflexes and promotes postural reflexes. Petos techniques, which repetitively teaching the same skill till the skill is learned. CMIT, which is constant induced movement therapy, useful in hemiplegic CP. Hippotherapy, improved neck control in sitting position, TENS and NEMS. Occupational therapy, which improves hand-eye coordination of the children and play areas of the children. Braces, the devices which hold the extremities in stable position. For example, AFO, that is ankle foot orthosis, which is used to maintain foot in plantigrade position. Orthopedic and surgical procedure. These are generally done in single event. Multiple level surgeries are to be done to avoid multiple exposure risk of anesthesia. Soft tissue surgeries are done from 4 to 6 years of age. Hand surgeries are done from 6 to 8 years of age, and more than 8 years of age, bony surgeries are to be done. Speech therapy is equally important. Drugs used in cerebral palsy. Baclofen, tizanidine, and diazepam are used to reduce the spasticity. Botulinum toxin, that is Botox, which weakens the skeletal muscle by impairing impairing the regulation of neurotransmitter at NMJ junction. For focal hypertonia, we use Botox. It can be injected in multiple muscles. The injection first given between 18 to 24 months of age. Intrathecal baclofen is tried for GMFCS grade 4 and 5. For dystonia, triaxiphenidine and gabapentin are used. For drilling of saliva, glycopyrrolate is used. Antiepileptic drugs for epilepsy. Anti-GERD drugs for GERD, which are metoclopramide and domperidone. For constipation, polyethylene glycol and higher fiber diet is given. For sleep management, melatonin is given. And for behavioral disturbances, risperidone is given. Associated problems in CPN management, 60% of children are intellectually impaired, 30 to 50% are having epilepsies. Vision problems such as refractive error, squint, amblyopia, optic atrophy are not uncommon. Hearing problems such as sensory neural hearing loss is also not uncommon. So we need audiologist and ENT. It is multidisciplinary approach is needed. For communication problems, speech and language delay is commonly seen. Oromotor dysfunction leads to failure to thrive and feeding problems. Gastrointestinal problems such as repeated GER and constipation. Respiratory problems, repeated GER leads to aspiration pneumonias, and in premature babies, BPD are not uncommon. Osteopenia and fractures are there due to reduced mobility and impaired nutrition. Behavioral problems such as ADHD, self-injurious behavior, learning difficulties are common. Sleep disturbances, dental caries, contractures, decubitus ulcers, and pain are some associated findings with CP. Cerebral palsy and co-mimics. Spastic quadriplegia is DD of spastic quadriplegia is leukodystrophies like Krabbe's disease, PM disease, and other metabolic myopathies. Spastic diplegia, Arginase deficiency, familial spastic paraparesis, tethered cord, spinal cord tumors are common. Ataxic CP, DD for ataxic CP is ataxia telangiectasia, orbital hypoproteinemia, spinocerebellar ataxia. For dyskinetic CP, Leishman syndrome, glutaric acidemia, Rett syndrome are co-mimics. Overall survival of children with CP is until age of 20 years is 90%. Good prognosis for walking, independent walking, head control to be attained by 9 months of age, sitting should be attained by 24 months of age, and floor mobility should be attained by 30 months of age. Thank you.
Thank you, Dr. Sheetal,
Manjusha,
completing topic in such a short time, within time. And I invite Dr. Udani sir for expert comment. Dr. Udani sir and Dr. Vinit.
Thank you, Doctor. Very good coverage of the whole topic. Just a few points. I think it's important you mention about MRI, and I agree that we should not do MRI whenever there's a perinatal obvious story. Everybody gets MRIs in preterms who have CP or HIE who have CP. I mean, there's no real need, and sometimes you get multiple kind of MRIs every time, as if some things are going to change. So it's really not really required. You should only do it when absolutely indicated. And I think the mimics part is very important. So if you have a patient, there's no perinatal history, or there's a consanguinity, or there's family history, or there is something different about the patient, or you have spastic quadriplegia with normal IQ, what looks like normal IQ, then maybe you need to do some more investigations. Second thing is about counseling. I think she mentioned is obviously very difficult to finish in this much time, but we don't counsel enough. We don't counsel what to expect and what are the goals of treatment. I think that is lacking in most people because, it's busy, it takes time. Maybe you need to call him and inform him. I mean, very gently, of course, you got to break the news over a few visits, but basically you have to tell them, and I think she gave a very good, that if you don't sit by 2, if you don't sit by 4, you won't walk. If you sit by 2, you'll definitely walk. So I think those things are very important because parents want to know, chalegi ki nahi? That's the important point. The third thing she mentioned about just a few things, Bobath and all these therapies are actually not that important now anymore. The problem is people should do active physiotherapy. So the physiotherapy should encourage movement. Only that will really help, improving. And they don't give home programs. You must insist to your therapists, whoever you're sending to, that call them once or twice a week. Don't make them come every day. But God's sakes, give them home programs, because home programs they can do at home as well. I think she mentioned very good about the drugs. Only one thing about, I tend to avoid benzodiazepines. So diazepam for CP, spasticity and all this, really not something I would use because it causes a lot of drooling, it causes a lot of dysphagia. And these patients already have that. And that's important about feeding issues, which we don't spend enough time on. How much time does it take to feed? Does a child enjoy feeding? Does he cry every time he sees a bottle? Does he choke? Does he's gaining weight? Because these things, as it is, the child is miserable, then you make him more miserable because he can't swallow. And in severe children, maybe, should gently introduce the topic of PEG. You put a PEG in, then you maybe help him in that. I think that's about it. I think it was a very good topic there. And you mentioned very well about the mimics, I must say. One thing about mimics, remember ataxic CP, always take with a pinch of salt. Most ataxic CPs do not have CP. Remember that.
Yeah.
Okay.
Yes, sir.
I think it was well covered. I think most of the points I think Sarah covered, and whatever the earlier suggestions she has already covered. But just the same one thing again, the same thing where I'm repeating. I think the pattern of the injury. I think the way the child was in an ICU and type of insult the child had, and now what is the morphology, what is the clinical phenotype. I think this all hypothesis should match. If there is a little mismatch, get an MRI done. Otherwise, don't do MRI randomly. If you have a doubtful insult of HI and you're getting a significant microcephaly, that could be some cerebral dysgenesis, lysencephaly, or something like that. So I think in the advent of the genetic area, we should not forget that we may miss those genetic or metabolic disorders. But yes, of course, if there is a specific history and already it has been proven HI and you are getting a proper adequate phenotype, I think neuroimaging is not needed. So for all the conditions, if there is a mismatch of your morphological and in the clinical phenotype and the pattern of injury or the birth event, if there is a progressive neurodeficit, if there is a diurnal variation, if there is a waxing waning course, or as Sir has already said, the ataxic cerebral palsy, always do your attempt to diagnose. It could be a CP mimic case, and you can make a significant change in the management. Thank you.
Thank you, Dr. Sheetal and Udani sir and Dr. Vinit. Now I invite Dr. Manjusha Sherkar for further proceedings.
Okay, thank you, Manjusha. Now I invite fourth speaker is from Vidarbha Zone, Dr. Samruddhi Vasnik. Dr. Samruddhi, you please start sharing your screen. Samruddhi is from IIP Chandrapur and she is a consultant pediatrician at Vasnik Hospital, Chandrapur. Her topic is SOL, space occupying lesions of brain. Over to you, Samruddhi. Samruddhi, I request to stick to time. Huh?
Ma'am, go to slideshow and make it full screen. Click on the slideshow button. And kindly unmute yourself.
Go to slideshow, Samruddhi.
Yes, click on from beginning. Just click on from beginning. Slideshow and yes.
Yes.
Yes, ma'am. It's working. Thank you.
Please be in time.
Unmute yourself.
Yes. Good evening to all the respected IP members. I am Dr. Samruddhi Vasnik and my topic of presentation today is space occupying lesions of the brain. So what is a space occupying lesion? It is any lesion occupying a physical space inside the cranial cavity, which may expand in volume, pressurizing or displacing the adjacent neuronal tissues and leading to its complications. Its incidence is higher amongst 5 to 9 years age group. What are the mechanisms leading to the symptoms? A space occupying lesion may compress, invade, infiltrate the normal neuronal tissue, causing a focal neurodeficit. It has a mass effect and CSF obstruction, which can cause hydrocephalus. Then it causes irritation of the cortex, leading to seizures, and angiogenesis and disruption of the blood-brain barrier, which can cause the ions and the proteins to flow freely across the extravascular space, and thus causing the fluid to get drawn into the interstitium, thus causing edema. So what are the types of space occupying lesion? It may be traumatic, that is extradural hemorrhage or subdural hemorrhage. Then vascular causes, it may be AV malformations, that is abnormal arteriovenous connections, that may be congenital. It can be venous thrombosis also, that is thrombosis of the intracranial sinuses, which can lead to raised ICT by impaired venous drainages. Then it can be infective, abscesses and neurocysticercosis. Then it can be inflammatory, that is granuloma and tuberculoma. Tumors, that is benign or malignant, and congenital, that is inborn errors of metabolism. Basically presenting with the affecting the amino acid pathways, for example, organic acidemias, glutaric acidurias, which may present with basal ganglia and white matter injuries. So when to suspect? The probability of space occupying lesions in infants and toddlers up to 2 years of age, when they present to you with bulging fontanelles, poor feeding, irritability, high-pitched cry, seizures, and sunset sign, mostly because of raised ICT. And in older children, they may present with headache, which may be severe and worsen with any activity or in early morning. And the headache is mostly non-throbbing type because it occurs due to raised ICT and not due to blood vessel spasm. Second presentation may be vomiting, which may be unexplained and projectile due to pressure over the medullary center. Then personality disturbances, seizures, diplopia, visual disturbances, cranial nerve palsy, ataxia, and motor deficits, all are pertaining to the specific site of lesion. According to a literature published in the pediatric emergency care, the most common presentation of a patient in the emergency department will be headache, hydrocephalus, vomiting, gait disturbances, vision changes, and behavioral mood changes. And the patient might also present to you with cranial nerve palsy, altered sensorium, backache, neurodeficit, ptosis, and microcephaly. So by now, as we all know that the major complaint is headache. So I've tried to include some of the diseases such as subarachnoid hemorrhage for differentiating the diseases. So in subarachnoid hemorrhage, patient will present to you with sentinel headache. What is a sentinel headache? It is the worst of its kind, first of its kind, and it may be associated with sudden loss of consciousness. And specific finding will be in CSFs, we can find xanthochromia. Xanthochromia is basically yellowish discoloration of CSF, but it is not pathognomic as such because it can happen in lot of samples with traumatic LPs also. But if it occurs in samples with less than 5,000 RBCs, it might indicate probability of a subarachnoid hemorrhage. Then migraine, it has a typical aura and history, and it worsens with the stimulus. Then meningitis, clinical presentation is more important in this, and CSF is always diagnostic. Then venous thrombosis, it might be a complication for ear infections and as well as underlying any bleeding diaphysis. And patient might present to you with loss of consciousness, and even cerebral angiogram or venography is diagnostic in diagnosing this venous thrombosis. And lastly, infarction or in the ischemic stroke, then half of the pediatric strokes are ischemic stroke, and carotid or Doppler can help you in diagnosing infarction. So we come to the investigations of the in any patient presenting you with this presentation. So a complete hemogram, ESR, PTINR, and electrolytes for differentiating any other diagnosis. Then lumbar puncture and will be helpful in diagnosing meningitis. Mantoux test if you are suspecting any TBM. X-ray skull is as such not diagnostic, but it can show calcifications, and chest X-ray might when be possibility of a primary complex or something. Then CT and MRI, practically now it is impossible to practice in the neurology field without fair access to CT and MRI because it helps in the fair understanding of SOL. Then it helps in localization, contrast enhancement, calcification, etc. And if you suspect any mass or lesion showing in the CT or MRI, then we have a gold standard, that is biopsy, which helps in the understanding the nature of the SOL. Then Doppler studies, and it can help in underlying bleeding diagnosis, diagnosis. And if it is an incidental finding in fetus in ANC ultrasound, then we can take help of fetal MRI also. Neural axis should be screened for CSF seeding or spinal cord drop metastasis. It is the most important point because even the CNS tumors do not metastasize outside the CNS. We come to the important slide of differentiating between neurocystic sarcosis and tuberculoma. So neurocystic sarcosis is the commonest parasitic infection of CNS. It presents in vesicular, colloid, granular, and nodular stages. And a Scolex is mainly formed in the colloid state, and patient will present to you with seizure, headache, and hydrocephalus. As we can see that there is a CT, the CT showing multiple disc-shaped lesions which are scattered all over the brain. And anti-helminthic drugs, steroids, and prevention are the main modality of treatment. In tuberculoma, it is a tubercular granuloma, which is a well-defined benign focal mass, which is caused by Mycobacterium tuberculosis. It usually presents similar as in SOL, and pathognomic signs are meningitis, neurodeficits, and papillary edema. And MR spectroscopy is a diagnostic which shows lipid peaks, and anti-tuberculous therapy is the main modality of treatment. We come to the brain tumors, which are most common type of solid childhood cancer and secondary to leukemias and malignancy. The predisposing factors being inherited genetic syndromes, radiation injury, neurocutaneous syndromes, and metastasis. Neurocutaneous syndromes, for example, neurofibromatosis, which may predispose to gliomas and meningiomas. And incidence rate will be is around 0.3 to 2.9 per 1 lakh children. Types can be supratentorial and infratentorial. Then fetal MRI is increasingly practiced based on the ultrasounds to detect congenital brain tumors. Its prognosis is better than in adults. I tried to include the benign as well as malignant tumors. Pituitary adenoma and craniopharyngioma being almost non-malignant types. As we can see that there are intense lesions that are occurring in the pituitary fossa, and pituitary adenoma mostly presents as prolactinomas because it has a tendency of having hormonal disturbances and dysfunctions. So basically it has medicinal treatment like dopamine agonists such as bromocriptine or cabergoline, and surgical resection is only limited when there are complications such as ICT. Craniopharyngioma, as we can see, that is hyperintense lesion occurring in the Rathias pouch, and it is the most common benign tumor that is presented with endocrine dysfunctions such as thyrotropin and corticotropin dysfunctions. And diabetes insipidus is also commonly presented in craniopharyngioma, and surgical resection is the main modality of treatment here. Then we come to the malignant tumors, medulloblastoma. It is, as we can see, that there is a midline tumor. It occurs mostly. It is a highly malignant and grade 4 tumor, and it has a tendency to spread to the spine. And it is a midline tumor covering the fourth ventricle, mostly spreading to the spine. That is why radiotherapy is always given to the extending to the spine, because it has a tendency to metastasize towards the spinal cord. And the chemotherapy being cisplatin, cyclophosphamide, vincristine, etc. Then in pilocytic astrocytoma, it is the most commonest malignant tumor in pediatrics. As we can see, there is a focal, well circumscribed lesion with cystic lesion with a mural nodule also. And the most common site is cerebellum. And it has a good prognosis with a 5-year good survival rate of mostly 90%. So my take home message will be, never underestimate a headache with a personality change. It could be SOL. Thank you for patient listening. Over to you, ma'am.
Thank you, Dr. Samruddhi. Now I invite Dr. Udani sir for expert comment, please.
Maybe again, Vineet. your
Vinit,
ball.
Dr. Vinit.
So I think very well covered. Just to mention about the few points, I think again even the markers for the probable exol in the younger childhood. If you have a unilateral head deviation, or if you're an acute onset meant like a torticollis, I think that has to be taken with a pinch of salt. If you acute onset cranial nerve palsy or headache, or if you have as she has already described the type of headache, especially in younger age, they have head banging, which is the narrative of this thing. And in context of other neurocutaneous syndrome, most of the things she has mentioned, but a unilateral head deviation or the torticollis is one thing I think we should not miss, and that could be a probable sign of probable exol. So I think most of the points she has very well covered in that short span. Over to sir.
Yeah, thanks for an interesting review of the thing. There's a few points. One is that I think you mentioned about, I don't know whether I missed this, but you mentioned about papilledema. And that is something which is unfortunately it's not seen very often in acute situations. So I think you must understand that in acute situations, the absence of papilledema doesn't mean anything. Second thing, I think maybe you mentioned this also, there was a lot of things going on, so I was not sure, but headaches which you are worried about in kids, which are the headaches which you worry about? So if a patient comes to you with headache, what do you think? This is a sinister headache. Maybe there is hydrocephalus, maybe there is some tumor or whatever. Is ones which wake you up in the night. So if a kid gets up in the night, 2 o'clock, saying because of the headache, that's scary. Second thing is young children. Though migraine can occur as early as 5 years, 4 years also I've seen. Usually, very young kids rarely complain of headache. And therefore, they should be imaged, I think. Third is maybe recent onset of headache is always more of a red flag than something which is going on for a long time. And progressive headaches. And of course, other things like if you have large heads and if you have, deficits and all that, of course, those are sinister. What imaging should be done? I think there's no place for skull X-ray. And I mean, even DSAs nowadays are rarely done. It's only nowadays you do. So all these things are really in the acute situation when there is no access to an MRI, it's difficult to do an MRI. A CT is still good enough to exclude most SOLs. But if there's time, you can do everything into the MRI and nothing else is really required. You can do everything, angios, everything else. So that's an important point. I think that's about it. I think most of the things you've covered otherwise. Thank you very much.
And in papilloedema, I think most of the people are confusion that you will have a lot of visual deficits. So papilloedema may not have visual deficits. This is another point I want to tell, because only clinical finding is the enlargement of your blind spot. Otherwise, your vision is far maintained.
Correct. So if you have papilledema, normal vision usual. If you have papilledema with visual loss, papillitis. Or ophthalmitis.
Thank you so much, sir, for those words of wisdom. We are so much privileged, actually. Thank you, Dr. Vineet, and thank you, Dr. Samruddhi, for that lovely presentation. Congratulations. Now is the turn for last speaker from West Zone, Dr. Trupti Bhosle. Trupti, please start sharing your screen.
Yes,
Trupti? Yes.
Yes, ma'am.
Trupti is pediatric neurologist from IIT Kolhapur, and she is a consultant pediatric neurologist at Neuron Child Neurology Center, Kolhapur. And her topic of presentation is encephalitis. Over to you, Trupti.
Yes. First of all, I would like to thank IIP, MAHAIP and MAHAIP Women's Committee for giving me such a lovely opportunity. Encephalitis per se is a very large topic to cover in just 8 to 10 minutes, but I'll try my best to convey as much as possible. Let's begin with some basic definitions, not to confuse with meningitis versus encephalitis. So meningitis is as we have already seen, is an inflammation of meninges. They usually present with the fever, headache, neck stiffness, often bothered with the light. Whereas encephalitis is an inflammation of brain tissue. They have the viral prodrome, new onset seizure, focal neurological deficit. Another term is encephalopathy. It is a syndrome of altered sensorium, and encephalitis is strictly a pathological diagnosis. So what causes encephalitis? They have either infectious causes or the non-infectious causes. Among the infectious causes, herpes simplex virus is still the most common cause worldwide in both children as well as adults. Others are the measles, enterovirus, listeria, rabies. Here the careful history taking is very important. Suppose if you have the history of ingestion of the unpasteurized milk, think of brucella. Having unpasteurized cheese, listeria is more likely. And please do take the travel history properly. Though in our area, in the periphery, we don't have, but in the metro cities or the large cities, you often have the families who often travel abroad for the vacations. So if you have a history of the travel to the Italy, you can get sandfly bite, which will cause Toscana, ultimately causing encephalitis. History of kayaking, think of leptospirosis. Hill walking in certain regions of the Austria can cause tick-borne encephalitis. Among the non-infectious causes, the most common cause is autoimmune encephalitis, in which again the NMDR encephalitis is the most common, most identified condition. Others are the limbic encephalitis, GAD, Casper2, because of encephalitis, demyelination conditions like the ADEM, NMO, MOG, then the acute necrotizing encephalitis, FIAS, Hashimoto's encephalitis, and some inborn errors of metabolism. Now, how they present clinically? What are the symptoms? Children usually have the viral prodrome, subtle behavioral changes to begin with, new onset seizure, strictly unexplained by the pre-existing seizure disorder, cognitive decline, abnormal movements in the form of dystonia, chorea, ataxia, tremors, sometimes the language dysfunction, even up to the mutism. This is a diagnostic criteria stating the definite, possible, and the probable encephalitis. The major criteria includes encephalopathy lasting for more than 24 hours, and minor criteria includes the fever, seizure, focal neurodeficit, EEG, as well as the neuroimaging suggestive of brain inflammation. In autoimmune encephalitis, in younger children, usually you have the abnormal movements as a prominent feature along with the seizures and the behavioral changes. As you can see here, as the age progresses, the behavioral issues or behavioral changes are the characteristic feature in the autoimmune encephalitis. So how will you investigate any child you are suspecting encephalitis? Do you have the blood investigations, do PCR serology, rule out the infectious causes? On CSF, you can get the pleocytosis, mild elevation in the proteins and the glucose. And if you are suspecting the autoimmune encephalitis, check for the antibodies. You may get periodic lateralizing epileptiform discharges characteristic of herpes simplex virus encephalitis. Extreme delta brushes are on EEG is a characteristic of NMDR encephalitis. And my sincere request is please do MRI within first 48 hours of presentation or the admission. These are some classic MRIs: bilateral medial temporal lobe involvement in the herpes simplex virus encephalitis, basal ganglia thalamic involvement in the Japanese encephalitis, ultimately progressing to the NMDR. The bilateral symmetric thalamic hyperintensities on the T2 flare image is characteristic of acute necrotizing encephalitis. And again, this is a MRI in the patient of NMDAR involving insular cortex, cingulate gyrus, and the inferior temporal lobe. The next one is the flames, the classic characteristic feature of the MOGAD. You can see the cortical hyperintensities along with the leptomeningeal involvement, enhancement, which will give the flame-like appearance. So if you have the flames, think of MOGAD. This is a schematic presentation for the systematic approach to any child you are having high clinical suspicion for the encephalitis. Go with the first tier investigations, do PCR, CSF analysis, rule out infectious pathology, start acyclovir, broad spectrum antibodies. If there is no response, you are having the persistent behavioral changes, abnormal movements, review your diagnosis to the autoimmune encephalitis, check for antibodies. Now, while measuring the antibodies, the major issue is where where in the CSF or in the serum. So the neuronal surface antibodies like NMDR, GAD, GABA have more sensitivity in the CSF, and the glial antibodies like MOG, aquaporin 4 have the more sensitivity in the serum. Now, how to treat encephalitis? This is one nice chart. I will not go in detail showing the antiviral, antibiotic, and antifungal agents of choice depending upon the pathological agent you have. If you're dealing with the autoimmune encephalitis, then earlier you start the immunotherapy, better will be the outcome. And one more thing I would like to highlight is not all autoimmune encephalitis are antibody positive, especially the limbic encephalitis. Many of them are antibody negative. So in such cases, if you have the high clinical suspicion, child is not improving, then do start immunotherapy as early as possible. The first line agents are the IV pulse methylprednisolone, IVIG, or the plasma exchange. If no response within 2 weeks, escalate to the second line agents like rituximab or the cyclophosphamide. In some children refractory to both first and the second line agents, you can try intrathecal methotrexate and the tocilizumab. Finally, the maintenance therapy is required in severe cases for up to the 6 to 12 months, depending upon the course and the severity of the disease. And the least emphasized, yet the most important aspect of the treatment is prevention of secondary hypoxic brain injury. We don't want only the survival, but we want the healthy survival with the good quality of life. You often get the children with the encephalitis having secondary hypoxia and go in regression. This causes the large socioeconomic burden and the impact to the family as well as the children. Others are the symptomatic treatment for the seizures, your abnormal movements, and the psychiatric illness. Tumor searches. If you are dealing with the NMDR encephalitis, if you are dealing with NMDR encephalitis, then always check for the paraneoplastic tumors, especially the ovarian teratoma. What are the recommended searches? The MRI or the abdomen pelvis, you can do the USG ovaries or the testes. CT and MRI chest for all the children less than 5 years. What is the recommended duration? The post-pubertal females you can do annually up to the 2 years, and in patients with the relapses annually up to the 5 years. Finally, certain clues to the diagnosis. If you are having unexplained fever, uncontrolled seizure, non-traumatic CSF with plenty of RBCs and the medial temporal lobe involvement on the MRI, then think of HSV encephalitis. Abnormal movements, language dysfunction, extreme delta brush on the EEG is again the characteristic of anti-NMDR encephalitis. Because of brainstem encephalitis usually have the triad of ataxia, areflexia, and the ophthalmoplegia. The faciobrachial dystonic seizures are classic of limbic encephalitis. These are certain clues to the MRIs, and finally the IEM. So this is one nice chart given by Bain and et al. For different antibodies characteristics of autoimmune encephalitis. Thank you so much.
Thank you so much, Trupti, for this excellent presentation, good slides, and too good. Now I request Sir to have his expert comments.
Yeah, I think it was an excellent presentation. I learned a lot. Basically, I think important to realize one thing that, there was very little to really criticize in this presentation, but just a couple of points I think I have to emphasize. I think, I think scrub typhus is now becoming a very important cause of encephalopathy, encephalitis in children, especially in North India. And that should be kept in mind. I think that's one thing. Second thing is, of the autoimmune encephalitis which have been enumerated, there are lots of them. There are only 3 which in my experience at least, and even most of the people's experience, are important. One is, of course, NMDR. So all pediatricians should know how to recognize that. The second is MOG encephalitis, which I think she gave a very nice picture of flames. But I think those are the 2 conditions where you need to remember the clinical pictures, because you might miss it and you might call it something else. For example, in MOG, you might have prolonged fever, you may have leukocytosis, you may have high CRP, and you may have an encephalopathy. So it might, and CSF, which is abnormal. So you might think it's a bacterial meningitis. So I think these are the important points. I think the last thing I think was I was remembering about the treatment. So when if you suspect autoimmune encephalitis and the antibodies come negative, please don't be afraid to treat it as such. I think she emphasized that as well, because seronegative autoimmune encephalitis is a real term, and we've seen several patients. It's just that the antibodies haven't been found. At some stage, they will. So I think otherwise this presentation was excellent. Thank you.
Thank you, sir. Thank you. Dr. Vineet, you want to say something?
There is nothing much to say. Just to add that non-infectious causes or these autoimmune causes are on a lead as just compared to your infectious causes. So we have to be very, as a pediatrician, we must be aware of this condition as truly said by sir, and we need to be watchful for this. It means clinical presentations and timely pickup can alter the prognosis. So I think it was a very excellent presentation. Thank you.
Thank you. Thank you, Vineet, sir. Really, indeed, it was a true excellent presentation by all speakers. Thank you, Trupti. Thank you, sir, Dani, sir, and thank you, Vineet. Sir, we want to ask 2 questions on the YouTube. Shall I take these questions?
Sure.
First question is asked by Dr. Lalit Mesh. Adolescent girl with GTC with normal examination and normal MRI EEG, how to go for AET?
Well, whenever you have a first unprovoked seizure below the age of 10 years, you're more comfortable that this may not recur. Once you cross that 10-year, 11-year kind of threshold, when you go into adolescence, when you have the first seizure with a normal girl and normal everything else, the most common cause actually is idiopathic generalized epilepsies, or what are called genetic generalized epilepsies. And unfortunately, these tend to recur. So, of course, you should do an EEG. And if the EEG is normal, you may elect to wait. But the EEG has to be done on sleep deprivation, because very often it is done on awake EEG will be normal. But you have to make the child, the adolescent sleep at 2 o'clock, get up at 5 o'clock and do an EEG in the afternoon without sleep. And then he gets sleepy over there. That's when you pick up the discharges. And you get the signatures of the genetic generalized epilepsies. If you get that, you must treat. In a girl, you can't use valproate, or you should not use valproate as the first drug. Only use it if it's not coming under control. So you need to either choose the 2 important drugs, which not only have no effect on weight, which is very important for a young girl, also no teratogenic effects in case you have to use it for a long time. So a levetiracetam, or nowadays you can even use brivaracetam, but generally I think stick to levetiracetam, and the other one is lamotrigine. And if you use lamotrigine, you have to go very, very slowly, because that's I think the best drug for this, lamotrigine, because that's not only very effective, but also has the best side effect profile except for rashes. So you have to just go very slowly while bringing it up to normal dose.
Yeah, I completely agree with this, sir. I think, again, the activation, most of the EEGs, they don't do activation procedures like hyperventilation or the photic stimulation, which is very important for picking up this idiopathic generalized epilepsies. And if it is not done and if the EEG is reported normal, I think a best attempt has to be made to do it perfectly. Otherwise, everything I think sir has covered well. There was another question.
Yes, there was one more question from Siddharth Parab. Role of intraventricular antibiotics in refractory ventriculitis with hydrocephalus in preterms. What is the role of intraventricular antibiotics?
Vineet, you want to take this?
I don't much use this intraventricular antibiotics.
Very rarely used.
Yeah, most of the time is not, but the only time when I think it could be used is when you have very rare organisms like this name now, yeah, where you have to use, for example, resistant Pseudomonas, or there's a new one called Elizabeth something. I forget the name always. Forgive me. But in those, you might have to, where meropenem maybe also, ibipenem also may not be sensitive. Then you may have to use things like colistin. And colistin, unfortunately, doesn't cross very well. You may have to use in the intraventricular. But generally, most of the times you use antibiotics, and so many are there with good CSF penetration. So you don't really need to use most of the times.
Thank you, sir. There was one more question. If at all raised ICP is manifesting in neonatal meningitis, is there any role of second tier management like CSF drainage in critically ill neonate as of in critically ill pediatrics TBI?
I'm sorry, I didn't understand the question. What was it again?
If at all raised ICP is manifesting in neonatal meningitis, is there any role of second tier management like CSF drainage in critically ill neonate as of in critically ill pediatric patients?
So I'm assuming he means how do we say CSF drainage? Now, yes, there is. I mean, basically, if you have meningitis, you obviously can't do a permanent shunt. So in the past, I mean, still in many good ICUs where there's a lot of infection control measures which are taken, you could use external ventricular drainage. But external ventricular drainage, is something which needs complete asepsis, needs a lot of nursing experience, where you actually cannot touch the areas which are, because introducing infection is pretty common. It is in my experience in ICUs which don't have this kind of asepsis followed. So if you don't have that, then you could try Ommaya reservoir. Yeah, the problem with the Ommaya reservoir is when you put a Ommaya reservoir, it's not a shunt, it's just a shunt. It's a tube into the ventricles with a little bulb, and you keep aspirating that so that you reduce the pressures. At the same time, you reduce the, but even that is the main thing is you might colonize the Ommaya itself, and you may not be able to eradicate the infection completely. In patients with raised pressures, for example, in other conditions, now neonatal meningitis is a different ballgame, but in other things like, for example, ventricular hemorrhage, people have used, when there's no infection, people have used temporizing measures like, ventricular subgaleal shunt. So when there's blood also, you can't shunt. So you drain that into the subgaleal space in the scalp and wait for some time, and then you put a shunt once the blood products have come down. So there are different ways of managing. Obviously, you have to have a good neurosurgical colleague who will look after this.
Thank you, sir. Thank you so much. Over to you, Manjusha Sherkar, madam. Vinit, you want to add something?
No, I think already covered by sir.
Patil sir, you want to add something?
No, I do not want to add something. It is well covered by everybody. We are still.
Yes.
But
So,
question for sir and Vinit also. How far the cases of recent adenoviral epidemics are manifesting as meningitis? And if it is CSF proven PCR, adenoviral infection, how to manage it in addition to supportive management?
I'm not sure there's anything else you can do because there's no treatment as such for the virus itself. But I agree, there's a lot of it going around. The only positive thing which I've seen, and I've seen a few cases, not too many, is that they do all very well. In spite of looking very sick, generally they improve. But sometimes it's a real problem. They come with encephalitis more than meningitis, the meningoencephalitis kind of picture. And sometimes you find even hemorrhages in the brain. So But I don't think there's anything specific besides supportive treatment, managing the seizures, managing the, the different metabolic parameters, managing ICP, etc., etc. More than that, I don't think you really can do anything specifically for the viral.
I do agree. So the natural course, I think it seems to be better, though they
Yeah,
appear.
milder. It's
Yeah.
milder, yes.
Sir, I have got one more question. If at all we are fortunate enough, bacterial meningitis coming to us without receiving antibiotics. So what with the steroid? When should we give steroids? It should be prior to first antibiotic dose or simultaneous or within
both.
minutes
Yeah,
prior?
yeah, see the Cochrane review, there was a study, let me tell you how this thing came about. Initially, the Cochrane review about this said that in development, I mean, all patients of meningitis should get, I think, 4 doses or something of dexamethasone, either before or just with the antibiotic. And then there was a study that was done in, I think, one of the Latin American countries, I think it was Brazil, where they found that, in fact, the patients who were given steroids did worse. And the reason they postulated was that because of antibiotic usage, which is so prevalent in all these developing countries, that you already, because what you're trying to do with steroids is what? That before the antibiotics hit the bacterium and cause a lot of the, bacterial products and cytokine release and all that, which causes all the complications, you're trying to prevent those things by giving steroids. And that has already occurred by the time they come to us. So I think that's why the study was negative. And therefore, the new Cochrane review says in developing countries, don't use steroids. So I don't know whether you want to use steroids, but you will be absolutely certain no antibiotics were given, and if you're certain, you can give it. How many doses? I can't remember. I think it's 4 doses or 4 days. I'm not sure.
4 doses, 12 hours apart.
Yeah.
And one last question from my side to both Vinit and sir. Before 10, 11 years, in first unprovoked seizure, if it is not status epilepticus, and we are not sure that it is fitting into some clinical syndrome, whether we should advise EEG in all these cases, or rather, when should we advise EEG?
We need to take it if you want. Rather add a few comments here.
Vinit.
Yeah, so I think in any case of status, usually go for an EEG because of the age, because of idiopathic epilepsy is again common. So if you're getting an EEG, which is an abnormal one, and though it is not fitting into a syndrome, but if you have a focal abnormality, usually we treat it with anti-epileptic. If it has a focal dysfunction, then we can give about 6 to 8 weeks of anti-epileptics, just like acute symptomatic seizures. But otherwise, if it is an unprovoked seizures, usually even if it is status, we don't continue. If there's a EEG is totally normal. I think sir can add his experience.
Yeah, I mean, my thing is, when I do a first, EEGs we do for everybody, yes. But why do we do the EEGs? The diagnosis of seizures is not from the EEG. When you have a number of patients who have normal EEGs, and you have a number of patients who do not have epilepsy and have normal EEGs. So you really cannot depend on the EEG for diagnosis. Basically, it's a witnessed event. And witnessed event has to be taken in some detail and possibly videos. If you want, because the videos are very helpful, but the first seizure really comes with the video. So that is the second reason to do an EEG is if you're not sure from the history.
So I think that has to be taken photo of the clinical situation as well.
That's right. So if you, otherwise, and the other thing is, if you're not sure of type of seizure, that's important because sometimes you have a kind of absence kind of seizure. You want to make sure the absence and not some focal, what is now called focal non-motor impaired awareness seizure. Very long word, but basically means complex partial seizures. If you want to differentiate between those two, maybe you can do an EEG. Otherwise, really, main thing is diagnosis and choice of medication. That's really important. Treatment-wise, it all depends. If everything is normal, I tend not to treat, but
I have one
So-
question. Can I ask?
Yes, please.
We are talking about EEG. So I have one question, sir. While withdrawing AEDs, what is protocol follow-up for EEG and withdrawal of antiepileptic drugs?
I mean, it's a complicated question. We know one thing, that if the EEG is abnormal at the time of discharge, most of the times there'll be an increased risk of recurrence. Especially if the first EEG, especially if there's one of those, slightly difficult to treat epilepsies. But at the same time, if you have a benign epilepsy of childhood, EEG may remain abnormal for many years, and the seizures may be one or two only, and after, suppose you elected to treat also, and the seizures are not there for us to, I would take a chance and stop the therapy. So there are epilepsy prediction tools. You can type it in Google. It's a very good, it's an adult and childhood thing. It's not purely for children, but it's an epilepsy prediction tool. You can just go through that list, tick it off, and it gives you a percentage of risk percentage. Even if you don't do an EEG, doesn't matter. It gives you a risk percentage. You can ask your patient whether you want to stop or not, depending on the list. Generally, anybody below 50%, you could stop. Anybody above 50%, you do stop.
Thank you, sir.
Thank you, sir, and thank you both the experts. We all are overwhelmed with the expert guidance, and thank you so much. Here we end today's Tuesday Tech session, and I request Women Committee Co-Chairman Dr. Neha Singh for giving formal vote of thanks.
Thank you, Dr. Manjusha ma'am. I, Dr. Neha Singh, being the co-chairperson on behalf of Maha-IP Women's Committee, first of all would like to thank Dr. Rajesh Sudani sir and Dr. Vineet Vangre sir for accepting our invitation for being the expert of today's Tuesday Tech program. Sir, your expertise, comments, and guidance how to solve any pediatric neurological case has always been very simple, straightforward, and very helpful. Thank you so much, sir, to both of you for being part of Maha-IP Tuesday Tech. I would like to thank Maha-IP President Dr. Ramakant Patil sir and our Secretary General Dr. Amol Pawar sir for giving us their support and Maha-IP platform. I thank Maharashtra Medical Council and our MSc Observer of today, Dr. Sanjay Gosavi, for granting us all the participants 1 MMC points for today. I thank all the 5 speakers of today, Dr. Manoj Thamke, Dr. Rahul Patil, Dr. Sheetal, Dr. Samruddhi, and Trupti for preparing beautiful presentations and delivering their topics excellently. Also would like to thank our Women's Committee Chairperson Sonali Shrivate ma'am, as well as other members of Women's Committee for helping in organizing today's Tuesday Tech. Thank you all. Thank you, Dr. Hemant Gangulia sir and Dr. Renu Boralkar ma'am for joining as well as motivating us. Then I would like to thank Dr. Manjusha Sherkar ma'am and Dr. Manjusha Giri for wonderfully moderating today's program. Thank you to all the EBs and OBs of Maha-IP for joining us and giving their full support. Thank you, Pallavi ma'am, for giving us the technical support. Last, not the least, all the Zoom as well as live YouTube channel attendees for joining us. Requesting everyone to please join our next Tuesday Tech on 16th of May. Thank you so much.
Thank you,
Thank
Dr.
you.
Alok Gupta, sir. Thank you, Dr. Alok
Thank you,
Gupta,
sir.
Next session from Maha-IP
Maha-IP and Ramakant
dialogue on 20th Thursday.
Thank you.
Thank you, Vineet sir.
Thank you, sir.
Udani
Good
sir.
night.
Thank you so much.
Thank you.
Nice,
Yeah,
Manjusha madam.
tomorrow
Both
there is
Manjusha
tonight.
madam.
Thank
Thank
you.
you, madam.
Night.
To have